Hi everyone, I'm Rohan from the UK. I'm with Anna from Spain, Hayden from America, and Francesco from Italy. This is the first report of the CovidSurg data, including 1,129 patients. Francesco, can you give us an overview of the study, please?
The main goal was to assess the 30-day outcomes for patients undergoing surgery who acquired perioperative SARS-CoV-2 infection. SARS-CoV-2 infection was defined as infection diagnosed within 7 days before or 30 days following surgery.
Thank you. Could you share the key findings, please?
The overall 30-day mortality was 24%. Nearly half of patients had pulmonary complication after surgery, and 38% of those died within 30 days following surgery.
So this clearly shows that operations during the COVID era are quite dangerous for patients. Haytham, are there any particular risk factors that led to worse outcomes?
Turns out that male gender as well as age more than 70 matter. Those patients are almost twice the risk of mortality. In addition, an ASA grade of 3 to 5, malignant disease, emergency or major surgery also increase the risk of mortality. But most importantly, it's worth noting that all patient subgroups had higher mortality than their historical controls before the pandemic.
And how does this data influence your daily practice?
I think the two take-home messages from the data is one, you should postpone or cancel elective surgery if you can afford to do that because the mortality is very high during the pandemic. And number two, this data is very helpful to counsel the patient and their families before surgery and set the expectations correct.
Thank you. Anna, are these findings widely applicable?
This data is from a wide range of specialty and procedure, which are described in the full text. The pragmatic inclusion criteria make it broadly applicable across different settings, as SARS-CoV-2 diagnosis was done through a positive swab, a positive CT scan, or clinical diagnosis if the previous two were not available.
And if I haven't registered just yet, is it still worth my center doing so?
Definitely. Further analysis around perioperative risk stratification, elective and emergency surgery, and specialty-specific context is still to be done and published, so new centers are very welcome.
Thank you, everyone.